Today, as you all know, is World Health Day. And really importantly, the theme for today's World Health Day is diabetes. I'm really delighted that this year's World Health Day has been on diabetes. It signals, to me anyway, that global health leaders have started to wake up to the fact that diabetes is a problem. They haven't yet stepped out of bed and put their feet in the slippers and started to really act, but they have started to wake up to the problem. And today we're going to discuss access to insulin, which is one such area that we should somehow be able to find a solution to.
Thank you, Justine, for the introduction. As Justine mentioned, why this spotlight on insulin? I think what's important to remember is that this life-saving medicine was discovered in 1921. And it was first given to an individual in 1922. And then in the 20s and 30s, it became widely available in the Western world. There have been documented challenges accessing insulin in terms of availability and affordability. And this review article that Mark Ewan, Richard Lang, and myself co-authored in the Lancet Diabetes and Endocrinology highlights some of these. And what's estimated globally is that 100 million people need this life-saving medicine. The global insulin market was valued at $20.8 billion in 2012, and 88.7% of value was controlled by three multinationals, namely Novo Nordisk, Sanofi, and Eli Lilly. I think it's a good signal from the global health community that World Health Day today is focusing on diabetes, because up to now, really, there has been a lack of a global response from WHO, from governments, as well as civil society. That's part of the reason for having this event today. Is we want to share our findings, we want to discuss our findings, and we want to get your perspectives and also the perspectives of the panel that we have here today, representing different points of view on the issue of access to medicines, and really discuss this issue.
Wrapped in its vial, insulin every day continues to extend my life. How is it that almost 100 years since its discovery, some have to beg, scavenge, and plead, and more, just to be given the privilege of its use? At least half of the estimated 100 million people with diabetes worldwide who need insulin do not have access to it, and people are dying.
But from a political perspective, even though you can say that progress has been made at the global level, what we're really seeing is a lack of translation of those global commitments down to national action. And so governments are meant to be developing national NCD plans by 2015, and we know that only 50% of countries around the world have national NCD plans that are costed, which is so fundamental.
What for me is very important in the story of this disease is the empowerment of the patients. I mean, it is one of the disease where chronic disease where really the patient is master about his illness, is able to diagnostic if he needs the insulin or not, or to measure exactly. And this empowerment of the patient is something I think that is also a model for other chronic disease and very important. But the empowerment of the states, the empowerment of the medical system who has to provide this is far not so developed as the empowerment of the patient themselves, and the accountability problem Hans raised is, in my view, perhaps the most important. Thank you.
I think somebody has to have an accountability to seek why can't this be. For example, in Tanzania, chronic diseases are free as a policy. If you have a chronic disease, you have to have a free access to drugs. You have to have free access to commodities. But then practically on the ground, it is not possible because that policy is not translating into a financial implication.
Our role needs to change to be one of the watchdog, one of being the one that's really knocking on government's doors to say, you have just committed to providing, 100% access to insulin in your country. However, I know in my clinic down the road, that's not happening. So I really think that there's an opportunity for kind of transforming the civil society movement to much more one of a watchdog, obviously continuing the advocacy that needs to carry on as well.
The device is also very important in this issue because, as you have heard, it is not only the medicine that is sold by the company who are now the dominant company in the world, but the way the medicine is brought to the bodies of the patients, and the devices make it now make an obstacle to the accessibility and to the price of the medicine.
What's worrying to a certain extent is the increase on patents on the delivery devices. So the new pens or other devices that are used to deliver insulin, meaning that potentially this could be a barrier, being that people will be stuck with one delivery device for a specific type of insulin.
It's a public policy failure to rely on the markets to solve this problem. And that's why my conclusion is that we need strong public policy interventions for this sort of thing. So what would it be? And I agree very much with the strong link with universal health coverage. That will give at least strong buyers, probably more treatment guidelines and a way to design a basic package that includes the necessary care, including insulin. So good selection and really focusing on those medicines that offer the best value for money. And then better prices, more competition, price information, taxes, good quality, new generic manufacturers or new biosimilar manufacturers. The pre-qualification is one way of doing that. So that would be basically improving the market by strengthening the buyers.
Now having availability of insulin, if you are as a health budget, if you are at the district level and if you are the district medical officer, your budget, you are given certain amount of money for buying the medicines. So you look at what are your priorities. So if you buy insulin, that will consume 50% of your budget of the health at that hospital, while the remaining 50% is to cater for 90% of the diseases which are there at the district level. So the priority of the district medical officer would not be insulin, would be how many more people can I manage with a little budget. So the whole game plan had to change, that how do you actually change the mindset of the people saying that this is one of the essential drug, which is life-saving drug.
For some parents in parts of Africa and Asia, as sad as it is, having a child die from diabetes can actually be a relief. They no longer have to foot the bill of insulin, which means they can pay to send their other children to school and to support their whole families. I have friends alive today, even though their doctors told their families, don't bother. It's best you let her die. She will be too expensive to take care of, and you don't need that burden and expense covering a shadow over your family.
Currently, we have more than 2,000 children in Tanzania on insulin. They get continuous supply of insulin. But the second challenge now is to making sure that these children are taking their doses on time. Because you find that when you give them insulin, the parents, the community, they say that, okay, the insulin, you are doing well, so instead of taking 3 injections, they take 1 injection. And you have some parents who basically, because there is no food and they can't eat and they have to take 3 injections a day, and if there is no meal available, they skip the injection. So you find that those are the challenges.
From a health systems perspective, I think it's so important when we're talking about access to think about systemic approaches to improving access. And what I mean by that is really trying to reorient the whole health system to address NCDs and chronic conditions, which is so different from when you're talking about a health system addressing infectious diseases.
In the meantime, we see a strong pressure to newer products, marketing, newer products which do not necessarily give much additional advantage. And it would be okay if you had enough money. But if buying one type of insulin at the price that you could also pay, say, treatments for 10 other patients, then it's not wise.
The change from human insulin to analog insulin is a question. 2 young girls I am responsible for lived this change also in fear of having not access to the analog insulin in the same way and to the same price as they had before with the human insulin.
Is there the need for a global compact on human insulin? We've seen shifts in the market from human to analog insulin, which is much higher as the price data shows. And so a concern that many people in the diabetes and insulin community have is that vials of human insulin will disappear, meaning that people will not have access to a quality product that is affordable.
If we say that you could do that in 2 ways, you could try to have economic measures to make sure that generic insulin is on the market, that you have the quality supported, etc. So you create the competition to offer some counterweight. But I suppose there's the prescribers and the patients. And if the prescribers are being bombarded by studies to test analogues comparing to normal, which we would call seeding trials. I mean, how many 100,000 people have been involved in seeding trials to find side effects we all know already there? But let's indeed also there call for transparency. Are these claims true, and is it worth the money difference?
The importance of competition. I mean, it's not only IP, it's competition. And IP is not the only reduction or barrier to competition. We have also to see what are rules in some countries, because there are limits also in some countries to a real competition, but also to see how the market is functioning. And the study we heard today is very useful in that sense.
But we used to have the rule that after a patent expires and you get the generics or the biosimilars, in this case, you get the competitive, have multi-source products on the market. It needs 5 products to bring the price to 1/5 of where you are. So the moment you have 5 competitive products, after a number of years, the price will settle at about, and at a certain moment it doesn't really help to get more competitors, because then sort of the bottom is reached. But it needs at least 5 competitors to reach that bottom.
Linked to the competition problem, we have the problem of the biosimilar. We have to find ways that the production of biosimilar is easier than it is now, that it is recognized also the possibility to have biosimilar accepted and registered and in good quality.
We're discovering the biosimilars regulatory barriers. Some colleagues from the University of Geneva and the School of Pharmacy are looking at those. We have other experts looking at it because it is something new. It's changing constantly, and it's hard to understand. It's a completely different language than many people can get through the legal terms.
Affordability is a question mark. Even if the generic insulins are there, they are only 5% cheaper than the original insulins which are in the market. So the generics are actually riding on the wave of the original suppliers and making profit out of it rather than really cutting down the costs. So the generic suppliers have to cut down the cost if we really need to bring affordability as an issue. And then comes the availability. And availability, again, would be that at different levels or different levels of the health system, how do we ensure that this insulin is available?
We are the select few who are aware that there is even an issue. A lot of people on the ground don't even know they're paying too much for insulin, don't even know all of this analog and human, and they just are not aware, so they cannot push to make change. They're sitting there buying it, begging for it, pleading for it.
I completely accept that there's not enough loud voices in the civil society space, and I would very much agree that perhaps in a way the NCD civil society movement is far too polite in our approach, that this is the social justice issue of our generation. But in order to build momentum and build community mobilisation around that, we need to obviously be using the language of equity and rights in our advocacy.
For people living with diabetes, access is the first step, and a quality of life free from the burdens and struggles is the goal. The price of insulin are the deaths and pains experienced by people living with diabetes, their families, communities, and countries, not what goes into the pockets of the manufacturers. It is the year 2016. People are dying, and we're nowhere near finished.